Welcome, listeners. It's a new season, and I'm back with a guest who has shared valuable educational content with us in previous interviews. I'm speaking with Dr. Tim Matatov of Southwest Breast and Aesthetics in Phoenix, Arizona. Of course, you can check us out and our conversation over at the YouTube channel when it's published over there and sit and watch us chat together about this great topic that we have today once that's published. As I mentioned, Dr. Matatov and I have shared this space before, educating those affected by breast cancer with microsurgical options for breast reconstruction. He's a highly skilled board-certified plastic surgeon who trained at Tulane University in New Orleans for plastic and reconstructive surgery. Now, Dr. Manitoff, I have to ask you a question because since I last visited your practice, you've added some new surgeons. Do you want to tell us about them?
Sure.
Give us a
Yes, we
just a
have.
little brief update.
So I think you've met Matthew Mino,
Yeah.
and then we've added Dr. Arvin Gowda.
Haven't
He
met him.
is, yeah, he's coming from a fellowship in Michigan,
Mhm.
and he's been with us for a year now. Also, Kelsey McClure, Dr. Kelsey McClure, she's joining us from the Mayo Clinic here in Arizona. And her interests are aligned with ours, mainly focusing on practice and breast reconstructive world. So we currently have five surgeons in the group.
Well, congratulations on your
Eh,
expansion.
Thank you, thank you.
Yeah,
So yeah,
yeah.
it's been great. It's definitely they've added some, and we've learning from something from them, and vice versa. And I think it's a good expansion.
Oh, that's good. That's good. Glad to hear. Well, congratulations again. Well, we're going to
Thank you.
talk today. I'm really glad to cover this topic with you about stacked flaps. Um, and what I'd like to talk to you about, Dr. Manitoff, is what stacked flaps are, first of all, you can give us a definition of that, but I know that not all patients are candidates for the traditional deep flap. So why would someone have a stacked flap? Where does this tissue, these blood sources come from in the body? And then, of course, what recovery would be like. So I'll let you take over from here.
Okay. Well, the original definition of the stack flap was that you put one flap on top of the other,
Mhm.
and still having to place two flaps into a surgical site. So in this case would be the breast. So that's what a stack flap is, and now it kind of evolved to more of like a flap from the abdomen, which is called the bipedical flap, where we have two blood vessels connected to the entire abdomen, and it's taken as one piece. So it's not no longer that it's used one flap over the other for volume. It's used mainly now, at least in our practice, for skin resurfacing in a radiated patient, where a lot of the damaged tissue would have to be removed, the skin would have to be removed, and there sometimes it's a fairly large defect, and one flap is just not enough just to even get skin closure.
Mm,
So that's the main setting we use this reconstruction on. And the second reason for us to use a stack flap in a single breast mastectomy, when a patient chose to remove only one breast and keep the other breast. And in that setting, when they do not have enough tissue from one side of either the back or the thigh or the abdomen, we would use a stack flap to match the volume of the current breast on that the patient's keeping.
okay. Okay.
And we have not been doing this as frequent because I think it's just a lot of surgery for patients. But in this third setting, you would use this on would be what's called the four flapper, where you would do two flaps in each breast.
Mm,
And a lot of times it is used for mainly size increase to increase the size of the breast, and I think there's other ways to do that that can be less taxing on the patient, but certainly doable. And that would be the third reason to use a stack flap, is just to achieve larger volume in the patient that may not have enough tissue for a single flap reconstruction. Those are the three main settings that it's done. But in our practice, it's mainly the radiation as well as single breast mastectomies.
So you're putting fresh new tissue and a blood source there where the radiation damage was in your first example.
Correct, and that is the main reason we do this for. It gives us ample amount of skin
Hmm.
and volume.
Hmm.
So in a radiated patient, it's there's an atrophy that occurs. It's ionized radiation. Therefore, every sort of if we'll get scientific about it, every electron in that area that was radiated, every atom, excuse me, every atom in that area has lost an electron. So it's permanently changed tissue that
Mm.
really cannot be undone. There's some improvements from bringing blood flow, but there's permanent change. So it happens at the breast skin level, at the pectoralis major muscle, sometimes the intercostal muscles and the ribs can be affected. So it's not just the breast itself or the breast skin, it's the whole hemich or half of that chest that gets affected. So in the radiated field, you need way more skin and way more volume than you would in a on the contralateral breast, that whether they had a mastectomy or not, just to achieve shape and wound closure.
That makes complete sense. I'm glad you brought up that point about the atoms. It makes sense to me, the change of that. So, when I think about the logistics of doing it, it sounds to me like you're using multiple, and I think you mentioned this previously, you're using multiple blood vessels that you have to connect together.
Correct. So the stack flap means two different blood vessels are being connected, whether they connect in series, and I can explain that, and or they're both are being connected into the chest vessels, which are the internal mammary vessels. So in the stack flap, the definition of that also is there's two separate microsurgical anastomoses of the artery and vein.
Hmm.
So just like you would do for a so it is a little bit more complex, um, and requires a little bit more skill to be kind of predictable with the success rate. And yeah, just a smaller field, a lot more traffic with blood vessels going from side to in all kinds of directions. So it takes a little bit longer. For us, a stack flap ends up being roughly the same time as a bilateral breast or both breast reconstruction.
Okay.
You're saving a little bit of time, but just the complexity of the stack flap and also designing the flap and shaping it in a radiated field just to achieve those the desired result, it just takes a little bit longer.
Oh, I can imagine.
So yeah, and even though we're doing one breast, it really becomes like a both breast reconstruction as far as time and effort.
Hmm. Yeah, I could see that. So what areas of the body then are we, what are the donor sites, so to speak? Is it
So
all from the
yeah, the most
tummy?
most common place it would be the tummy. Then second common place for us would be something from like a thigh, like a pap flap. Those are the main two ways that we do the stack flap reconstruction. But people also done it. Other surgeons have had great success with doing, let's say, when I was in training, Dr. Allen used to do stack LTP flaps, lateral thigh flaps. And then you can do, and you can stack S-gap flaps. It's a lot more complex, but you can get creative with that. And in the four flap reconstruction, you miss and match. Let's say you would use an inner thigh flap like a pap flap and a deep flap. So you can combine those as well, and to get four flaps out of to achieve that volume. The deep flap is shaped more like the triangle, and the pap flap is a crescent. So you can use the pap flap for the to rebuild the lower portion of the breast, and then you can use the D flap to kind of sort of put on top of that in a vertical dimension to reconstruct the mid and the upper part of the breast. They actually fit very well to give that natural appearance.
Yeah, yeah, the crescent shape where you can shape it, yeah. Um, so do you, once you remove the tissue from the donor site, do you do the anastomosis, say, I mean, I'm just curious and why I'm asking you
Sure,
this.
sure.
Do you do it like kind of off to the side, or do you transfer it all up and all of the anastomosis, or tying together, for those that are listening, tying together the blood? Do you see what I'm asking? Or is it all
Yes,
done
absolutely.
at the breast area?
So we do it both ways, depends on what's more ergonomic, and where can we shave some time off. So in the
Mm,
set, we've done it. It's called the back table, where you do it in the back while somebody else is working on other parts of of the case.
hmm
You would do it in the back table. Let's say if you are connecting. Sometimes there's like branches that are coming off the main tree trunk, sort of, or the blood vessel. So then you can connect the other flap to one of the branches on the back table, and then bring the whole construct to the chest or the breast, and then connect the main trunk or the blood vessel to the internal mammary vessels, and then this way it all gets reperfused. Other names for that would be like a daisy chain anastomosis or in series anastomosis.
mm,
The other way you can do that is you can connect the both flaps to the internal mammary vessels. One would be flowing with a normal pathway of the blood coming from the heart into
mm,
the flap, and that's called the antegrade anastomosis. And then the second flap, you can connect it to the retrograde. So what that means, the blood flow is not coming directly from the heart, it's coming around the whole system. Since it's a closed system, it comes around and then supplies that blood flow into your flap. So the antegrade anastomosis would have 100% of normal blood flow,
mm.
where the retrograde only gives you 70%
I see.
because it's not directly being pumped into the system.
Hmm
So, and that would be the two ways that you can reconstruct and do that.
mm.
And I know we've talked about apex flaps a little bit last time, but an apex flap pretty much becomes a stack flap. You end up doing the same amount of work, just a
I,
little bit
s-
less, potentially a little bit less harvesting that you have to do to get the flaps.
yeah, yeah,
But the concept is the same.
yeah. Yeah, it's really the creativity of harvesting those blood vessels and optimizing the blood flow by finding them and putting
The
them
right
all
one.
back
Right.
together. Yeah,
Right. Yeah, we're just
yeah.
trying to reconnect and plumbers. We're just trying to
I know.
recollect the plumbing to have the blood flow come in and blood flow come out, and make sure we don't what comes in has to come out. There has to be a match to inflow and outflow. But yes.
You know, Dr. Matatov, I'm recalling now a podcast that we did together about when you were explaining about the tree branches. I'm going to have to link that in this podcast as well so people can listen to that one because I thought that one was fabulous how you talked about,
Oh,
the blood vessels in the body. I remember that. Um,
thank you.
so tell us about, excuse me, tell us about recovery from this. Since the surgery is longer, does it mean longer recovery for the patient? I'm going to mute my mic
Uh,
so I can take a sip of tea while you're talking.
no problem. The recovery time if is the same, let's say, as a standard both sides bilateral deep flap. So because harvesting both vessels, both sides of the abdomen are harvested, and then but it's usually done on one side of the breast. So recovery is not much different than a bilateral deep flap or bilateral pap flap. Not much the same. And surgery does take a little bit longer, but again, not far from a bilateral deep flap, or again, same as the pap flap.
Hmm
So, and most patients don't even can't even tell the difference if it, we've taken one flap or two flaps from the abdomen. Usually one place will hurt more than the other, and it's not going to be all simultaneous, meaning at the same time.
Mm,
The body processes a lot of times just the most intense signal. So whether it's, two, three sites, you will be hurting and at any particular moment, but usually you're just interpreting that one most intense signal. So
interesting.
that
Interesting.
that's kind of how sometimes the brain processes pain. Yeah.
I think that, I'm trying to get into patients' mind here and what I hear from them. A lot of them are concerned about the blood vessels, you know, making sure the flap doesn't die because you're tying more blood vessels together, you're stacking flaps. Is there any greater concern about monitoring those flaps and how they have to kind of either through compression garments or minimizing their movement the first 48 hours or so? Is there any difference in that, Dr. Manitoff?
So the flap monitoring is we do monitor both flaps. But a lot of times this if you're having a stacked deep flap, you still have that middle of the abdomen that the blood flow may or may not cross. So and if we're replacing skin, you're able to see both sides of the abdomen. So we would put two sensors on that one breast
Ah,
to make sure to monitor.
okay.
And this is only done if we're doing what if the reconstruction was done with that antegrade and retrograde anastomosis, because now they have independent blood flow.
Mm,
If
okay.
one goes down, doesn't mean the other will go down.
Hmm.
If you're doing it in series, let's say you've connected one flap to the branch of the other flap, and then you connect that main one to the blood to the internal mammary vessels. In that situation, we only monitor the flap that's connected to the other flap.
Hmm.
Because for us, if we're monitoring just that one, if that one something happens with the T-stat, we know that it's either a problem with the flap to flap connection or the main connection. You don't need to monitor the flap that's going through because there's no point
Yeah.
because if you're going to be going back for something. If that one goes down, you'll know either one or all of it went down.
Yeah.
So for that, in those patients, we only monitor one flap. And that can only be done, well, it can be done in both. It can be done in stack flap as well, but a lot of times we use that in the deep flap system.
Okay. Interesting. And the T-stat system that you're referencing is one flap monitoring system that is used. You're going to see those little white lights for the T-stat system. It's
Yep.
oxygen in, oxygen out. So just as a reference for our listeners on that.
Yeah, it allows us. Sorry, go ahead.
No, 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 go ahead.
It allows us to monitor blood flow, and also it's remotely, I think that's the best part about for me. It remotely transmits data to my phone. And then I can look at it at any time, and this is why I know what's going on. And we've actually had a while back a patient that unfortunately was bleeding, and the T-stat picked it up earlier than the blood pressure monitor, because the oxygen all of a sudden dropped in the way that it's um, not that the flap is dead, but a significant amount. And that prompted a phone call to the nurse, and then nurse going in and checking, and the patient wasn't feeling well. So, yep, exactly. Exactly.
I know.
So
I I tell patients with T-stat, your doctor may get in his car and go home after surgery, but he's got you with him with the
yep,
T-stat
that
monitoring.
that
Yeah,
is 100% the truth. Yes, that's exactly how it
yeah,
is.
yeah. Um, so I want to field a question to you on behalf of patients again, because this is a procedure that takes, to me, it takes extra skill. It doesn't mean you're a bad surgeon if you're not doing it. It doesn't mean you're, not a qualified surgeon if you're not doing it, but not all surgeons are doing it. So what questions should patients be specifically asking their microsurgeon, whether it's you or anyone else, if they think and they listen to this and they think, maybe it's a stacked flap that I need? What conversation should they be having with their surgeon about this, Dr. Matatov?
Very good question. I think like it goes with most of the microsurgical breast reconstruction. One of the earlier questions is like how often is this being done? How
Mhm.
often are you doing this? For us, it's probably 2 a month, which is again not it's common, but not that common. Uh, and uh, and some plastic surgeons that don't do that much microsurgery or do enough stack flap can be a little bit challenging,
Mhm.
and I think mainly just thinking through the process and doing it frequently allows you kind of you do have to think a little bit outside the box with stack flaps, uh, because sometimes you don't have enough blood vessels, and
Yeah.
this needs to be planned, and you have to have um like a plan B just to make sure how do you figure out to reestablish blood flow to both. And you're doing 2 sets of anastomoses, and it can be taxing, and the day can be longer, especially if you don't do that enough. So I think volume is important with the stack flap, just like with all microsurgery.
Mhm.
Um, and then in the specific in the radiated patient, if there's a radiated patient out there and there's significant discrepancies between your breast sizes already, and patients feeling tightness from the implant, or let's say there is no implant, just somebody had a mastectomy and decides 10 years later after they've had radiation to have reconstruction, and you have to think about like, okay, how much fabric do I need to achieve a shape of the breast? And you can sometimes look down, and if you're a patient that's flat and you're looking at the other breast, if you have one or if you have an implant there, and you just kind of have to think about how much of this needs to kind of go over and under to recreate the breast. And that may be a patient that's for a stack flap. So I think that's important to think about, and also ask your plastic surgeon, is this a surgery that I would need? Would I have enough skin or even volume to rebuild the breast?
Mhm.
I think those are important questions, and I think these surgeries need to be done at least, and we do this pretty much every day. And I think these surgeries need to be done with a second microsurgeon, and that would be another question that I would ask: is like, is somebody doing this with you? Are you or are you on your own? And it's tough to do it on your own. I can probably do that, but that's a long day. That's a lot of effort. And I really think you need another experienced microsurgeon in this case. So that a team is important. I would ask about the team that is helping the main surgeon.
I'm really glad you brought that
Uh,
up. Two surgeon model,
oh,
two microsurgeon
absolutely.
model.
Absolutely, absolutely. I think like yes, you can do it on most of us can do it on our own, but the longevity of this and how often you're going to do that, and when problems arise, you need another. It's good to have another head that have seen this before, just back and forth, and just benefits. I think benefits the patient.
Oh yeah.
Um, and just the speed of the case goes significantly faster if you have another experienced surgeon in there.
Yeah.
So it was another side story, but Dr. Zacher and I were doing a case, and this was probably 5 years ago now, 4 or 5 years ago, and I like felt violently ill in surgery, and I had to like scrub out. I was in the operating room getting an IV, getting Zofran for nausea, getting like Toradol for pain. And while kept going with the case until I got the IV and got better, I went back and helped. But not that this happens often, but for
Right.
me, this is one of those things like, what would I do? Like, what would I do if I was on my own? So, and,
Yeah.
these cases take a long time, sometimes half a day, all day, sometimes, 8 hours, sometimes 10 hours, 6 hours, it all depends, but you just never know. And
Yeah.
I think that's what helps me do this daily is the fact that I have another surgeon.
Wow. Um, I like that answer. That's what I was looking for. I was looking for clarity, honesty, an example. What I want the listeners to understand from this, like Dr. Matatov said, not everyone's doing it, but fortunately, I'm talking to someone today who does. So, and oftentimes we know that patients do have to travel for these specific surgeries, even just a regular deep flap. So, I want to thank you again. If anyone's listening and they've heard the word stack flap, or this is something that you might benefit from, I'm talking to Dr. Tim Matatov today at Southwest Breast and Aesthetics in Phoenix, who is doing this with his partners. So thank you for joining me today and talking about this important topic.
Thank you, Sarah.
All right, great to see you again.